The spotlight of this CME will be on two important functional gastrointestinal disorders. Though we have a huge list which we have seen as per the Rome classification, the most common of the functional disorders are two, and they are the gastroduodenal disorders, under which the functional dyspepsia, and the functional bowel disorders under which the irritable bowel syndrome. So, we will be concentrating in this CME on functional dyspepsia, also referred to as FD, and irritable bowel syndrome, also referred to as IBS. These two will be our focus on this CME. The other functional disorders, though they are important, they are less common, so they are not part of this particular presentation. So, the question is, how do we identify our patients with functional gastrointestinal disorders? Not many tests are required for these people. Careful history taking and careful analysis of the symptoms will do to classify the patients into various functional gastrointestinal disorders. The classification, of course, is symptom based and not investigation based. Remember, it is important to exclude structural and biochemical underlying causes before we label a patient to be having functional gastrointestinal disorder. So, the absence of structural or biochemical disorder is the hallmark of a functional GI disorder. Most important thing is, all GI disorders are not functional. Some of them may be very serious, and they do present with what are called the alarm signs. We will look into the list of alarm signs in the subsequent part of our presentation. But remember that we must watch in any patient with GI symptomatology, GI disturbance, for signs of alarm signals, are also called the alarm signs. And once these are there, thorough and immediate investigation is mandatory to rule out structural and, more important, and treatable and dangerous causes before we embark on the diagnosis of functional bowel disorder. Clinical diagnosis and treatment will be highlighted in the presentation rather than emphasis on the investigations. Road to Rome. There is a book called Road to Rome, also called the Rome criteria. The Rome criteria are developed over the period of several years, Rome 1, 2 and 3, like that. Subsequent meetings have upgraded and then updated these disorders, the functional bowel disorders. The latest presentation is the Rome 3, which is published in 2006, and we shall adopt this Rome 3 classification and criteria for our presentation in this particular CME, that being the latest available as on date. Our generation is a generation of transition, also called the transitional generation. We were in the 20th century, we are living in the 21st century. The lifestyles, the mechanizations, the way in which man perceives things, the socio-cultural background of human beings has dramatically changed over the years when we see the last half of 20th century and the early part of the 21st century. So, this has shown its impact on the health and disease pattern of human beings too. From 1900 to 2000, if we move down, the incidence of gastric carcinoma has come almost to a very small proportion now. Peptic ulcer disease, once which was the topmost among all the GI disorders, has been coming down, and we don't see much of peptic ulcer disease as on date, thanks to the advent of proton pump inhibitors, H2 blockers, and Prokinetics, and many other medications. Surgery for peptic ulcer disease has almost become a rarity. Of course, there is nothing much to be happy about this drop in these two. We have a compensatory increase in functional disorders, or functional dyspepsia, and the other entity, it is not a functional one, gastroesophageal reflux disease or GERD. So, the place of gastric carcinoma and peptic ulcer disease of Esther Century has been now taken over by the functional dyspepsia and GERD, and there are many other conditions which are now coming up compared to what we have seen in the previous century. The functional dyspepsia and GERD are now called the diseases of the 21st century or the diseases of the modern man. So, let us now see about functional dyspepsia in this particular CME. GERD, of course, is out of scope of this particular CME. Look here, the regions of the stomach. Anatomically, stomach has 4 regions: the fundus, the corpus or the body, the antrum and the pylorus. This is what we have learnt in our anatomy. These multiple anatomic regions, when they come to the functional level, there are only 2 parts. The one is called the receiver or the gastric reservoir. This receives the food, churns it, stores it for a while, processes it, and by the virtue of the tonic contractions of this part of the stomach, the gastric reservoir digests the food. Then we have got what is called the antral pump, which includes the antrum and the pylorus. So, the receiver or the reservoir part is the fundus and the body. The antral pump is the antrum and the pylorus together. The antrum and pylorus together act as a pump, and they have phasic contractions. Functionally, there are 2 types of contractions. One is the tonic contractions of the gastric reservoir. The second is the phasic contractions of the antral pump. Functional, motor and anatomical regions do not thus correspond directly. In a way, it is important for us to understand the pump problem and the gastric reservoir problem. The treatment for the pump problem and gastric reservoir problem are different. That is why now the concept of understanding the stomach regions in terms of the function has come to light, and this we have to understand. The 2 cardinal symptoms of functional dyspepsia are epigastric pain, epigastric burning. Epigastric region we all know is here. Epigastric pain and epigastric burning sensation are the 2 cardinal features of functional dyspepsia, rather of any disorder affecting the gastroduodenal region. Remember, all dyspepsia is not functional. Dyspepsia has got various etiologies. There are various types of dyspepsia. When we say dyspepsia, it could be gastroesophageal reflux disorder, very common, GERD, or it could be unclassified or uninvestigated dyspepsia. Commonly, this is where we treat the patients, we do not investigate, they come with dyspeptic symptoms, we put them under UID and treat them first before we really investigate, unless they have alarm signs. Then of course, the GERD, then the dyspepsia due to peptic ulcer disease or PUD, then the other one is called the dyspepsia without there being any ulcer, also called the non-ulcer dyspepsia or NUD. All these, the UID, the GERD, the PUD and the NUD together contribute to around 40 to 50% of the cases of dyspepsia. The remaining 50-60% of the cases are of functional origin, and that is the category called functional dyspepsia, which we are going to see in the subsequent slides. So, remember, dyspepsia is not due to only one type of cause. There are various types of dyspepsias: uninvestigated dyspepsia, gastroesophageal reflux disease, peptic ulcer disease, non-ulcer dyspepsia. These being the organic causes have to be excluded before we dub a patient as having functional dyspepsia. Now, out of those types of dyspepsias which we have seen in the previous slide, two of them are most common. One is the GERD, the other is the functional dyspepsia, but they are not mutually exclusive conditions. GERD and functional dyspepsia overlap to some extent. So, 20% of the functional dyspepsias and 11.6% of the GERDs are exclusive, but 8.4% of GERDs and functional dyspepsias, they overlap in their symptomatology. So, to say the symptoms of GERD mimic functional dyspepsia overlaps with the symptoms of GERD. It is important for us to rule out GERD before we classify a patient as having functional dyspepsia and start treating him for functional dyspepsia, because the treatment for GERD should be aggressive, because we do not want him to develop esophagitis, we do not want him to have stricture, we do not want the patient to have Barrett's esophagus if it is GERD untreated, and that could lead the Barrett's esophagus, and the esophagitis can lead to carcinoma of the esophagus, which is becoming more commoner nowadays compared to previous days. Whereas functional dyspepsia has got no problem. It is not going to develop into any malignancy, there is no question of any stricture, no Barrett's or anything. So, functional dyspepsia as per Rome 3 criteria is defined as follows. Functional dyspepsia as the presence of gastric pain, epigastric pain or burning, postprandial fullness or early satiation in the absence of an underlying organic disease. So, if we put them as 1, 2, 3, 4 points, the 4 symptoms that are included by the Rome 3 committee are early satiation, that means the patient, as soon as he starts taking a few gulps of food, he feels full and he is not able to eat further. Postprandial fullness, patient complains of some vague uneasiness and then fullness in the stomach immediately following a meal, and then epigastric pain and epigastric burning. So, these are based on the Rome 3 criteria which are published in this detailed guidelines by the Rome 3. So, remember, functional dyspepsia must have the 4 symptoms: early satiation, postprandial fullness, epigastric pain and epigastric burning. The most important underlying pathology in functional dyspepsia or FD is gastric dysmotility. Dysmotility of the stomach due to various causes: abnormal antrofundic reflexes and intragastric distribution of food, antral dilatation, postprandial antral hypomotility, altered duodenal contractions, impaired adaptive relaxation of gastric reservoir, postprandial gastric dysrhythmias, delayed gastric emptying, solids more affected than liquids. So, these are some of the aspects of gastric dysmotility seen in functional dyspepsia. So, to reiterate the symptoms of functional dyspepsia: early satiation, postprandial fullness, epigastric pain, epigastric burning. Remember, no evidence of structural disease or organic disease, both clinically and by endoscopy. How do we treat these patients of functional dyspepsia? Functional dyspepsia, as we know, has got some functional element, the psychosomatic element, the gut brain interaction. So, reassurance plays a very important part. Lifestyle change in the food habits also is crucial for recovery of the patient. In this, one important point that we can stress to the patient is not to immediately lie down after filling the stomach or after taking the meal, at least to be up, walking or sitting for 2 to 3 hours until the stomach emptying occurs after a meal. That would definitely help. And again, in the lifestyle, we have got the diet changes like avoiding caffeine, alcohol, smoking, fatty food, things like that, which are going to increase the gastric acidity and then cause increase in the symptoms. Of course, behavioral therapy, including counseling and cognitive behavioral therapy, will go a long way in reassuring the patient and in reducing the symptoms. As far as the treatment is concerned, drug treatment is concerned, we have got two agents. One group is called the prokinetics, which control the dysmotility of the stomach. The second group is the acid suppressors. Acid suppressors, we have got the H2 blockers, which are older agents, and the newer proton pump inhibitors. Proton pump inhibitors or PPIs are far superior compared to H2 blockers as acid suppressors. Prokinetics, we will see what are the prokinetics we have and which one of them would be beneficial in our subsequent slides. Then of course, if the symptoms are not controlled by these methods like reassurance, change in lifestyle, behavioral therapy, prokinetics plus minus PPIs, then we can use antidepressants. Antidepressants of the tricyclic group, of the selective serotonin reuptake inhibitors. These can be tried in patients who are not responding to the other therapies. So, in nutshell, the treatment of functional dyspepsia is mainly reassurance, lifestyle modification, behavioral changes, prokinetics, PPIs and antidepressant medications. What are prokinetic drugs? Prokinetic agents are those which modify the motility of the GI tract, particularly of the gastroduodenal region, in such a way that the GI promotility drugs are used to stimulate either directly or indirectly the smooth muscle contractions, leading to enhancement of gastric emptying and acceleration of bowel. So, in a way they are making the gastric tone or bringing the gastric tone to normal levels. So, they normalize the gastric tonicity both of the reservoir of the stomach and of the antral pump. Currently, we have got several prokinetic agents. So, the older ones are the metoclopramide and the domperidone. These two have systemic side effects, particularly the CNS side effects. Cisapride and mazapride, these have cardiac side effects and QT interval prolongation, and the newer drugs like etopride, which is devoid of cardiac or CNS side effects or the extrapyramidal side effects. And then tegaserod is another newer drug which is very useful prokinetic. Levosupride and cinetapride are also newer drugs. So, among these, etopride probably is better tolerated than the other prokinetics. We have limited experience with levosupride and cinetapride. Tegaserod has got a specific role in IBS, which we will see a little later. Remember, all these prokinetics do work. All of them are efficacious. Only thing is, the concern is about the side effect profile. So much so, I would like to use drugs like etopride, which are having little side effects compared to the other drugs. As per the Rome 3 criteria, functional dyspepsia itself has got two different types. Functional dyspepsia, Rome 3 criteria, it classifies the functional dyspepsia into PDS and EPS. PDS means postprandial distress syndrome, that is, patient feels fullness of the stomach, heaviness in the stomach after taking a meal. This is meal related, whereas EPS or epigastric pain syndrome. In this functional dyspepsia, patient will be having epigastric pain and burning even though he is on empty stomach. It is not meal related. A meal related postprandial distress syndrome PDS, a meal unrelated epigastric pain burning syndrome called EPS. These are the two different types of functional dyspepsia. The meal related one, prokinetics are the drugs of choice. The meal unrelated one, the EPS, prokinetics alone are not sufficient. We have to use proton pump inhibitors also. So, if the patient has got mainly PDS, prokinetics will be the agents of choice. If he belongs to the EPS, epigastric pain syndrome, a combination of prokinetic and PPI will be the choice. Suppose the patient is not controlled with this treatment, an addition of antidepressant drugs will be required, and that will probably control the symptoms of the patients. Of course, along with the other treatments like behavioral therapy, lifestyle modification, reassurance also have to be borne in mind. So, with this we have completed the functional dyspepsia part of the CME. In the next slides we will be seeing the irritable bowel syndrome. What is IBS? What are the types? How to treat will be the part that we will be seeing in the subsequent slides.